Good afternoon. I'm James Downey. I'm the CEO of the Independent Hospital Pricing Authority, and it's my pleasure to welcome you to today's third session of our Q&A series. Before we get going, I'd like to acknowledge the traditional owners of the lands on which we're meeting on today, all around Australia. For me here in Sydney, it's the Gadigal people of the Eora Nation, and I recognise their continuing connection to land, water and culture, and respect elders today and those who walk in spirit. As you already know, each session in this series has covered a specific part of our ABF work that underpins the funding of public hospitals in Australia, and of course is used much more broadly than that as well, as we know. And today we are going to talk about the classification systems that we use, and this is a great example of where our work is used much more broadly than just in public hospital funding. IHACPA's been responsible for classification development since we were established in 2012, and that's grown over time, and we now have a full suite of classification systems that cover all hospital services, from the ARDRG system, non-admitted, emergency, subacute, the new Australian mental health care classification, and of course the teaching and training classification that we've developed as well. Currently we are in the final throes of developing 12th edition of ICD 10 AM, and we expect that will be approved and released early in the new year for implementation from 1 July next year. And we've got our Director of the Acute Care Classification team, Anne Ellsworthy, online, who can answer any and all of your questions on that. We've also got Natalie Bryant, our Director of Classification Projects, who's worked very closely on the development of ANSNAP version 5, and she's also here and very happy to take your questions. As I'm sure many of you know, in 2021, we introduced a new standard development cycle for all of our classifications. So we have a very strong commitment to continuing to evolve and develop our classification systems to make sure they maintain currency and reflect changes in service delivery. You also know, I'm sure, that we updated our data reporting and coding rules for COVID-19, and Joanne Fitzgerald, our Executive Director of Policy and Classification, led this work. So feel free to hit her with any questions you have around how all that works. We've been extremely lucky at IHACPA to be assisted by a clinical advisory committee made up of some really eminent and dedicated clinicians from around the country across all specialties and professional groups. And the chair of that committee over the last 5 years, I think, and has been a member of the CAC for almost 10 years, is Associate Professor Alistair McDonald, who's joining us from Tasmania this morning. I'm going to leave it to Trent to introduce the panelists as we go. And before I get out and let you start the discussion, I just really want to thank everyone who's involved in putting these together. It really is a big operation. Our comms team have worked very hard, so thanks very much to Ivonna and Hannah, and thanks, of course, to our panel. We've got over 500 people registered today for the webinar. They're proving extremely popular. So I really look forward to sitting back and hearing the discussion. So I probably don't need to introduce Dr. Trent Yeend. He's been the moderator for, I think, his third or fourth panel now. So when he's not a professional panel moderator, he's our senior data scientist here at IHACPA. And also has been an honorary senior research fellow at Macquarie University. He has a PhD in mathematics and 15 years experience in health sector data analytics and statistical modelling. He's been at IHACPA since we were established in 2011, so it's been a really integral part of the team So with that, I'll hand over to Trent, and thanks very much to everyone for joining us today.
Thanks, James. Good afternoon and welcome to the third instalment of the Independent Hospital Pricing Authority live Q&A webinar series. Today's session is titled Enabling Clinically Meaningful Classification Development, Understanding the Systems Linking Hospital Patient Data, Policies and Costs. So the session will focus on health-related classification systems, by which we mean clinically meaningful taxonomies we use to describe and code and organise our health information. Classification systems play a key role here at the Independent Hospital Pricing Authority. They are fundamental to the accurate representation of Australia's healthcare system within our national data collections, and they underpin the prices that IHACPA determines for our national activity-based funding system. More generally, these classification systems are a common language base that can enable and support communication amongst healthcare providers, administrators, and the broader population. IHACPA is responsible for maintaining a wide range of classifications spanning across hospital care types and settings. A really useful overview of these is provided in our introductory presentation available on IHACPA's YouTube channel. The purpose of today's session is to provide you, the audience, with the opportunity to engage directly with our panelists who share an extensive knowledge of these classification systems, as well as behind the scenes details of how they are maintained and refined over time. We have around 50 minutes to take your questions, which I encourage you to post via the Q&A widget on the right-hand side of your browser window. You can also upvote other audience questions that are of interest to you. Let me now introduce our four panelists, the first of which James briefly introduced, Associate Professor Alastair McDonald, the Chair of the Independent Hospital Pricing Authority's Clinical Advisory Committee and member of the Healthcare Homes Implementation Advisory Committee. Alastair is a clinical associate professor at the University of Tasmania and a physician working as Director of Medicine in a private practice in Tasmania. He is a past Royal Australasian College of Physicians board member, President of the Adult Medicine Division and Chair of Council. He is involved in physician training and a member of the National Examination Panel. Alastair was awarded the College Medal for Service in 2015, and he was a member of the National Lead Clinician Group, chairing the Tasmanian Lead Clinician Group. In the past, Alastair has served as President of the Internal Medicine Society of Australia and New Zealand and on committees for both the Australian Commission on Safety and Quality in Healthcare and the National Health Priority Areas. Joining Alastair, we have three of our senior leaders here at IHACPA, starting with Joanne Fitzgerald, Executive Director, Policy and Classifications at IHACPA. Joanne's many roles include overseeing the ongoing management and refinement of the wide range of classification systems IHACPA is responsible for. Jo also has more than 15 years experience as a health information manager, working with health classification systems in both the public and private sectors, including as a clinical coder, as a manager of medical record departments, and at the New South Wales Ministry of Health. Our next panellist is Anne Ellsworthy, Director of Acute Care Classifications at IHACPA. Anne has extensive experience in classification development, coder education and mentoring, clinical coding and auditing. Here at IHACPA, Anne is responsible for managing the ICD-10-AM disease classification, the ACHI health interventions classification, the Australian coding standards, and the ARDRG classification of acute admitted episodes. As a member of the Australian Collaborating Centre, Anne also participates on the committees for international health classification development through the World Health Organization Family of International Classifications Network. Our final panellist is Natalie Bryant, Director of Classifications Project at IHACPA. Natalie is a proud UN woman from the New South Wales South Coast. She has worked at IHACPA since 2012 across a wide range of classification roles, including overseeing classification development and refinement work in mental health care, emergency care, subacute and non-acute care, and non-admitted care. Natalie has also worked in the New South Wales Ministry of Health in activity-based management, managing the non-admitted and mental health care work program. Welcome to our panelists. So while we wait for the live questions to start coming through, I'd like to start our discussion today by asking Alastair and Joanne each for their take on the following question. In view of the relatively rapid appearance of innovative medical technologies, particularly in the hospital setting, what does IHACPA do to ensure timely and effective timely and effective adjustments are made to the classification systems and funding models to recognise changes in service-related costs?
Thanks, Trent. From a point of view of the clinicians and the Clinical Advisory Committee, we get involved in this at almost every meeting. The IHACPA undertakes a fair bit of horizon scanning, looking at new technologies, looking at them from the perspective of how they replace other technologies that exist and other treatment modalities potentially that exist. The sort of volume of the work that's being done and how they differ from existing techniques, and as a result of that, we're presented with a significant list, which we work through as a clinical advisory committee and determine the priorities for moving forward with developing classifications attached to these new technologies, and those that can potentially come back and have another consideration once the process of has developed fully, and so we may see technologies on 2 or 3 occasions over a year or two as they increase in volume and utility.
And to add to Alistair's explanation of that new health technology process, as part of the standard classification refinement cycles, there are processes built in for doing that horizon scanning. We have a process of receiving coding queries, of receiving public submissions. That portal is open all year to receive those submissions, and as part of the classification refinement, those submissions are reviewed, identified if there's technology that's not accounted for in the classifications. Another standard process is incorporation of MBS updates, so it really is built in as standard as our development cycle to ensure that we are using the latest technology and we are incorporating that when it's undertaken in Australian hospitals. One of the challenges of the timely implementation has been the development cycle involves the development of a standardized electronic code list to be built into software systems. And as new technology comes on board, we can't necessarily update software systems to accommodate new codes. We just can't add codes to those electronic code lists. So in the new edition of the Australian Classification of Health Interventions, we're introducing a mechanism of a series of placeholder codes, which will essentially sit within the electronic code list, which will sit in software and health information systems in state and territories and in hospitals, so that we can be prepared to activate particular codes for new health technology, similar to what we had to do with ICD-10 codes with the COVID pandemic. And that's one of the measures that we are introducing to improve the timeliness around new health technology, so that when we do identify a new technology that needs to be coded that's not adequately accounted for in the classification at the moment, we should be able to activate that code, and data collection can commence much sooner than would have normally been when we had to wait for a new development cycle and a new code list.
Okay, so I might ask Anne, how is IHACPA ensuring that COVID-19 is being accurately captured within our hospital data and appropriately classified within the ARDRG classification?
Yep, so we implemented the emergency use codes for COVID-19 that were released by the World Health Organization. They themselves don't actually inform grouping. They're essentially used as flag codes for the COVID-19 episodes and used in combination with other existing codes. For example, the asymptomatic COVID-19 would be used in combination with the emergency use code and an existing code for coronavirus to ensure that that would appropriately group into the infectious diseases major diagnostic category. And symptomatic COVID-19 will group in combination with the manifestation of COVID-19, such as the pneumonia, and group to a respiratory major diagnostic category appropriately. And also to keep in mind that the more severe cases will actually group according to interventions such as ventilatory support and go into a pre-MDC based on the intervention code rather than the disease codes themselves. So We have made sure there are measures in place to ensure the COVID-19 codes were introduced in a way that can identify those episodes, but also to ensure that they group appropriately.
All right, so Natalie, perhaps you could give us give the audience a brief rundown of recent activities in the ongoing work of AN-SNAP, AMHC and AECC classifications, being subacute, non-acute, mental health and emergency care.
Thanks, Trent. Yeah, certainly. So we're looking at finalising the AN-SNAP version 5, which is a modest refinement of the AN-SNAP classification. And the major change to that is really the recognition of frailty as a measure of complexity and a significant cost driver for subacute activity. We're introducing what we call the frailty-related index of comorbidities into the GEM and non-acute care types within the subacute care classification. There were other more modest refinements in relation to various weights and changes slightly in how variables were grouping, but overall that was the major change, and we're currently finalising that and looking to release it in early November. In relation to the AMHCC and the AECC, we're currently undergoing exploratory analysis to look at a roadmap really for the way those classifications can be refined going forward. So the AMHCC was first developed in about 2014 and has been implemented for data collection and has been implemented for shadow pricing in the admitted setting and is looking to be priced from 1 July next year. And we're looking at how we can improve using the variables that we currently have and how we can improve their use going forward, with a long-term view of looking at how we measure complexity. But that's still, the exploratory analysis has only just been finalised, and we've been discussing that with our mental health working group. We're doing a similar piece of work in relation to emergency care and the AECC, and again, looking at how we can use the variables that we currently have and how we can improve their use in the classification. And then also looking at some of the recommendations that were made as a result of the costing study and how we can implement those into future versions of the AECC, but without significantly burdening the clinicians in terms of the data entry.
Okay, thanks. So the questions I'm going to pose, feel free to jump in, any of the panel members. I won't necessarily pose it to particular members, but this one I feel might be going towards Anne's direction. So does IHPA educate clinicians on documentation for classifications and how coders need to see the documentation written to meet our Australian coding standards, or is this left up to hospitals?
Standards are really developed to guide clinical coders in applying the codes appropriately and accurately, but of course that is impossible unless the documentation itself is of a good quality and accessible to a coder. We don't educate clinicians specifically, but I know that there are a lot of hospitals and that have quality documentation improvement programs and things like that. Plus, we do have standards that relate to the data in terms of what is required and whether or not we do encourage coders to be able to engage with clinicians at the hospital level to understand the coding and what documentation is required, or submit an appropriate coder clinician query to clarify certain documentation if it's not adequate for coding. And I think there is a lot of programs like that out and about now. Certainly when we release the new edition of ARDRGs next year, we hope to be developing an education program that will be reach a wider audience in terms of clinicians and health service managers and things like that may seek to improve that link in the knowledge between, starts with the documentation and the codes. But certainly a coder's job is incredibly difficult if the supporting documentation doesn't support the assignment of codes accurately. But in terms of the standards themselves, they are mainly about trying to get consistency across what is, what should and shouldn't be coded. And yeah, and we work with our, you know, advisory groups, both clinical and technical, in terms of how we can improve that and get better links between documentation and accurate coding.
Okay, so this one is on models of care. So how does or could IHPA handle models of care as opposed to procedures, which are more costly but which lead to better outcomes? In particular, the questioner says, from my perspective as a stroke neurologist, stroke thrombolysis, which demands costly infrastructure, stroke thrombolysis, which demands costly infrastructure to provide it, and stroke unit care, which is the single most significant intervention to improve patient outcome, which is not captured in current funding models, to my knowledge.
I'll jump in with that one. So I guess it has, I mean, the question has sort of posed into funding models moving from classifications. So the classifications is about ensuring we have the data to be able to identify interventions, diagnoses, the care and the treatment that was delivered. So regardless of what funding model, you know, there can be flexibility in what funding model is applied. We need to ensure that that underlying data is there to be able to identify that care being delivered. Once we have that data in the classifications, then the funding model is something that IHACPA can look at, is looking at, and does look at. The area of future funding models is a priority area identified by the Commonwealth and all states and territories in the addendum to the National Health Reform Agreement, and includes a number of clauses around working together to look at innovations in funding models to focus on for where there are particular types of care that may be better under an alternative funding model to activity-based funding. So whether that's a bundled payment for stroke care, as the person posing that question has asked, that we do have flexibility to look at an alternative funding model where a type of care might be better funded under an alternative to an activity-based funding model.
Okay, thanks, Joe. So this question goes to the non-admitted classification system, the Tier 2 classification system. So non-admitted patient data in the community-based, in the community setting is grouped into the 40.08 primary healthcare class. Includes a lot of different services. Is there any intention to differentiate this class? And if so, what is the progress on this work?
I think that one's for me, Trent. So look, you know, the Tier 2 non-admitted services classification is a clinic-based classification, which, you know, I think is acknowledged that that is a shortcoming of the classification and something we do intend to do something about. We had commenced the non-admitted care costing study in 2018 and were 2019, sorry, and we're just about to commence live data collection in approximately 30 hospitals in February last year. And as you can imagine, COVID-19 caused that costing study to have to be initially delayed and then eventually cancelled. The intention of the costing study was to develop a new classification for non-admitted care, which was we were hoping to be patient-centric. So not based on the clinic that the patient attended, but based on characteristics of the patients and of the treatment that they were receiving. So in terms of those primary healthcare services that are provided in community nursing services and community nursing clinics and those types, you know, we were hoping to understand a little bit more about the patients and what care they were receiving and how, and then classified that care and those services in a different way that was more about those patients and more about their diagnoses and the interventions rather than the clinic by which they were seen. Unfortunately, you know, we are now 2 years delayed in that project, and we're hoping that we will be able to pick that up again next year. But obviously, you know, circumstances are what they are, and we need to liaise with the jurisdictions about how and when we're able to recommence the non-admitted care costing study, and that will inform the future direction of the non-admitted care classification. Can
I just comment there that I think that is is particularly now active in a lot of jurisdictions as we look to admission avoidance strategies and mechanisms. So I think there's a lot of interest amongst the clinical community in the direction that the non-admitted patient group takes, because in a sense that the way that we've delivered healthcare for so long has been that you fund activity within the hospital as opposed to funding activity by potentially hospital-based services in the community, and so I think clinically and as a clinical advisory committee we're particularly interested in that work getting back on track once COVID starts to become endemic as opposed to an epidemic.
Okay, so the next question goes to the actual consistency of the application, well, the encoding of information on medical record within the data across different jurisdictions. So in terms of classification and funding, how do IHACPA determine if all states are applying these rules consistently? For example, in some states include emergency department procedures within the admitted patient episode data, and others don't. So consistency of data. Anyone want to have a go at that?
I will start off. I was gonna leave it for Anne, but
yes, I was expecting Anne to say something. But...
Sorry.
Why don't I start off and then Anne can add to what I'm going to say. Obviously, there is, IHACPA is very focused on national consistency, and part of that's driven by the coding standards and the classifications, which I'll leave for Anne to discuss. There is another process around national data collections and national minimum data sets and consistency there. So IHACPA is one party of the, the committees and the governance around national data collections, and states and territories have a process by which they agree to national data standards, and they agree to report data in a particular way, and it is a requirement for states and territories that they do that in a consistent manner. And where there is variation to that, where they're submitting that data, whether that's to IHACPA or whether that's the Australian Institute of Health and Welfare, then they're required to provide data quality statements which explain whether they've complied with those standards or whether there are exceptions or variations so that they can be identified in the data. So that's, I guess, my take from national data collections. And do you have a view from a coding standards point of view?
So in terms of, probably that question is a bit broader than just the coding standards themselves, but what episode of care something is actually, like in an emergency episode of care, it can be driven by local policies as to what classifies an emergency admission versus an acute admission and things like that. So obviously emergency care uses the Australian emergency care classification if it's an emergency episode, but once it becomes an admitted episode of care, then the interventions, the acute admitted classification will have the coding standards for the acute admitted are different to the emergency. In terms of, so one thing that we did learn in a recent pilot or what was confirmed in a recent pilot of the refined version of 0002 for the 12th edition was that sometimes the coding is also influenced by the local rules and policies around that are added in terms of the standards. So we can do so much in, providing the standards in terms of national use for an episode of care. There are also other influences that are beyond our remit, I would suppose. Joe, I don't know if want to add to that, but in terms of, there is an admission policy issue around what becomes an emergency episode of care versus an admitted episode of care. So I think maybe that was where that question was heading a little bit.
It may have been. I was just going to add, you know, the issue about national admissions policy has been in discussion for many, many years. A number of agencies have looked at it, most recently the Australian Institute of Health and Welfare. I guess just to reiterate what Anne said, we provide national standards, we promote national consistency, and, you know, the application implementation, there is that role of the states and territories and the services who are collecting that data to ensure that they are following those national standards.
The other area where the Clinical Advisory Committee assists in this is looking at where the same process or procedure is undertaken either on an admitted patient or in the outpatient environment, and to determine whether it's a different cohort of patients that are admitted for certain procedures as opposed to dealt with as outpatients or as day cases, and to make sure that the way in which they're funded reflects any differences in the acuity, and where there aren't differences in the acuity or the service, to make sure that there's consistency of funding across those two environments.
Okay, so we have a question here on ICD 12th edition. So there's been a great amount of work put into the 12th edition of ICD 10AM, ACHI and ACS to make it more clinically meaningful. For example, updating the procedure codes for spinal procedures to reflect the work of the MBS review task force, or expanding the antimicrobial resistance AMR codes for consistency with the Commission's AMR surveillance system. What other exciting changes to 12th edition should clinicians or the health system be aware of that are clinically meaningful or maybe useful for policy making?
Yeah, so obviously the question comes from somebody who's seen a lot of the updates that are coming through for 12th edition. But yeah, so we have focused on updating the classifications in terms of currency, and included a lot of MBS updates, including that major spinal interventions update, but also the new placeholder technology codes. We've also we've included codes for new technology in terms of leadless pacemakers and things like that have come through previous new health technology framework submissions. The antimicrobial resistance codes have been expanded extensively. The sepsis coding has been updated in line with the sepsis 3 definition. So there is a lot of changes in terms of currency. The COVID-19 codes have been incorporated more comprehensively in the 12th edition as well, because at the moment we're relying on them having been implemented as emergency use codes, but they've been expanded significantly for the 12th edition to better support that classification in an ongoing way. Another important thing that's been done for 12th edition is to look at some of the outdated legacy terms and stigmatizing terms from a mental health terminology point of view. So they've been updated extensively as well. There's been numerous updates in terms of technology. The other important thing was that we implemented a principles-based approach and a prioritization approach in developing a framework for developing classifications going forward. And when that was developed and implemented, we then went back and used those principles to look at where there were gaps in the classification from a clinical point of view as well. And because of that, we've implemented several new things where we felt there was missing disease or intervention codes. And for example, we've included things like cytokine release syndrome. We've included updated classification for dementia to look at behavioural and psychological symptoms of dementia. Several new intervention codes based on a review of the submissions that outline those gaps. And so we've done a lot of work to ensure that the classification development is clinically up to date and based on those types of principles. But, you know, we will be releasing an education program that will extensively you know, outline those major updates going forward. And so, yeah, so, you know, once it's approved and implemented, I think, you know, people will see that there is a lot of valuable updates that have been made for the 12th edition.
Okay, so another COVID-related question. So reasons for COVID tests performed has not been well documented historically, while facilities in the past have been raising queries as per IHPA advice. In the current COVID climate in New South Wales, the little amount of documentation we saw for these tests has dried up significantly. We're experiencing pushback from the clinicians who are under their own clinical pressures and do not want to respond to these queries. What is IHPA's position on applying U06.0 to episodes, which is a disease code, to episodes where tests are performed, but there is not symptom or reason documented without raising a query? Does this impact on funding for LHDs or epidemiology if these codes are not applied where testing is done?
So that particular code was implemented specifically as part of the COVID-19 in response to the COVID-19 response, and it to be able to classify the testing activity around COVID-19 in the absence of having a specific intervention code in ATU to be able to classify COVID-19 testing. It's certainly, I know, been assigned in numerous numbers, and there are several frequently asked questions that are published on IHACPA's website in relation to the assignment of that code. In the 12th edition, that code will actually be removed in favour of a specific intervention code that can be used to classify COVID-19 testing. But Jo, I don't know if you wanted to say anything on the fact that that really was a specific use case. We wouldn't normally, as a routine code, tests like that. But for the COVID-19 pandemic, it was important to actually capture that information, and that code was used for that purpose.
Yes, that's the case. A national partnership agreement between the Commonwealth and the states and territories had a framework around funding arrangements for the COVID-19 response, and you know, we, like everyone else during the COVID pandemic, make decisions based on the information we had available, which was in, you know, between about February to April, May last year, when the major work was done. And so we had to make a decision on the basis of recognising that it was likely there was going to be a significant number of people presenting in hospitals and hospital activity related to COVID-19, but who were not actually diagnosed with COVID-19, that it was suspected or that they would undergo testing. And we needed to roll out that U06.0 code in order to identify that, so that we could identify those activities for the purposes of this agreement. And as Anne said, now that we can introduce that testing code in the interventions classification, that will no longer be required, and hopefully will make clinicians and coders' life a little bit easier.
Okay, thank you. So this is a question about the AN SNAP classification, the classification of subacute and rehab patients. So in the past, there was a great deal of variation in the allocation of subacute activity between jurisdictions. For example, crossover of patients with GEM and rehab, classes. Are there any plans to report on the current state of this variation between jurisdictions?
So we do quarterly activity reports that go through to our jurisdictional advisory committees, which looks at the variation in activity and cost and across the jurisdictions in relation to different care types. And depending on, I guess, the need for that quarter, the focus can be quite different. So a lot of the last year has been focused on variation in relation to COVID-19 and the impacts of COVID-19 on particularly admitted patient care. So in terms of, I don't believe there's any intention to release that variation publicly at this stage, but it is something that we do report through our jurisdictional advisory committees on a regular basis. And
to add to that, for those who work in public hospital services, IHACPA does have a national benchmarking portal, which includes subacute activity, and includes acute activity, includes a whole range of hospital activity. So for those states and territories and those working in public hospitals, be that clinicians or service managers, can access that national benchmarking portal, and that does report on, and reports can be run on a whole range of sort of stats on subacute, whether that's variation between states and territories, or what your hospital average cost is for a subacute patient compared to another hospital for the same subacute patient. So there is a lot of data currently available for that benchmarking portal, and IHACPA is working on expanding access and redesign of that benchmarking portal throughout the rest of this year and early next year. So a redeveloped portal should hopefully be available as well, just to flag that as work coming up.
Okay, so I've got a question on timely response, I guess, of the classification changes to the classification system. So, is it possible to get a definitive answer on what length of time timely actually means? I feel this might differ significantly across areas. So I feel the answer is it depends, but maybe it's what does IHACPA do to ensure that we're responsive to changes within the system with regard to our classifications and potentially the funding models as well?
I think you've answered that question, Trent. It does depend. I'm sure there are variations to what we view as timely versus what others view as timely. We always have to balance timeliness and classification refinements with what the system can manage as well. So, for example, we've traditionally produced new versions of the admitted acute classifications every 2 years. And for some, that has been nowhere near timely enough to account for new technology. And for other stakeholders, it is quite a significant burden every 2 years to educate the workforce and implement a new edition. So we do work with all stakeholders to try and get agreement and a way forward on what is considered timely for classification refinement. In relation to new health technology, which we talked about earlier, we have, for the admitted hospital classifications, for the admitted setting, for ICD 10AM and for ACHI, we have a quarterly process of updating coding rules. So as coding submissions come in, that advice can be issued. That advice might not be a new code that can't be implemented mid-edition at this stage, but the advice will be, this is how you code it in the interim. So that advice, in our view, quarterly is as timely as we can make it. And as I said, we always have to balance that timeliness with the burden of making system changes and educating the workforce in updates to classifications. I might hand over to Alistair to see with his view, I guess, from the Clinical Advisory Committee on the timeliness of new health technology and what he sees, I guess, in his practice.
Yeah, I mean, I think there are issues occasionally with timeliness, and to use one of the examples given earlier by somebody who referred a question, the changes, for instance, in the management of thrombolysis in strokes to clot extraction, which is rapidly becoming the standard of care in organisations that have the capacity to do it. And the costs involved in clot extraction as opposed to thrombolysis meant that it's been something that we've discussed on a couple of occasions at the Clinical Advisory Committee in order to try and move that process on, because the setup costs to do clot extraction are quite significant compared with having a thrombolysis service. But I think our experience on the Clinical Advisory Committee and as a clinician is that most of the time the advice given allows us to move forward in line with the next with the next edition, and there are options presented to try and achieve that. And I agree with Joe that I think it's that it is difficult mid-edition, so to speak, to make changes, and at the same time, most of these changes that we're making initially are for very small volume. It's when they become large volume issues that it becomes more important to be timely, I think.
Okay, and so maybe another follow-up question with regard to timeliness. So with regard to the actual ICD classification, is there an ETA for the gender reassignment classification codes, Anne?
So they haven't been refined 12th edition, but it's certainly been put on the work program as a priority for a future edition. There's been a lot of work around removing the sex edit variable from the DRG classification so that we don't rely on that variable going forward, which will make the reporting at least of sex and gender and the grouping facilitate that in a much easier way. And we have updated codes in the ICD classification in order to support that work. But for gender reassignment surgery, I know there is more work to be done in that area that we haven't actually incorporated for 12th edition, unfortunately.
Okay, thanks. So, so this next question is on the home-based care and mental health care. So we have a growth in hospital-based mental health care provided to patients in their homes. This is not quite substitute inpatient care, hospital and homes, but there are a range of alternative models of care. Patients do not need to be admitted, but they require more intensive care than can be provided in the community mental health setting. There is an emerging type of activity that is in between admitted and non-admitted. Can you comment on where this best fits within the classifications?
Thanks. So I guess, the classification for mental health care is, the first split is based on setting. So it is about whether it's admitted or in the community. And if it isn't a substitution for an admitted patient episode, then it would therefore fall into the community version of the classification. And there is, within the Australian mental health care classification, there is the ability to classify, I guess, that more intensive type of care through the phases of care. So we would expect that depending on the type of care being provided to a consumer in their home, they would be placed into an appropriate phase, and then the cost for that phase would be reflective of that level of intensity. So we are proposing to shadow price community mental health this year using the AMHCC, but currently community mental health services are predominantly block funded. So it is quite different. But in terms of the classification, the question about how we classify that care, it would be classified into the community branch of the AMHCC, and then it should be grouped into the appropriate phase of care, which would then, as I said, flow on to hopefully a sort of a more consistent classification for that greater intensity of service. It's also worth noting that there is an ongoing discussion at the national level through the data committees in relation to like virtual care and different models of care and how that can be better captured. And that our conversation is sort of happening through the committees run by the Australian Institute for Health and Welfare. And, virtual care is becoming more predominant, I guess, more prevalent in the way we provide care. And there's perhaps part of that conversation will address those sorts of issues around that in between admitted and community. It possibly also could be captured under the innovative models of care work that IHACPA have been doing in the future, but for now it would be classified under community, to answer that question fairly simply.
Okay, so onto the scope of service event definition. While the non-admitted Tier 2 classification is in place, what are the challenges for IHACPA to broaden the service event definition to meet the use of new and emerging virtual care technologies related to remote home monitoring and wearable technology?
I think I almost just answered that. So it is a challenge for us in terms of how we do that. We do have, in the non-admitted Tier 2 services classification, we do have the ability to capture where a patient is seen by a telehealth, where that is a direct substitution for a face-to-face consultation. And there is a telehealth code for the clinician end and a telehealth code for the patient end. And that's to capture the additional costs of, having a telehealth suite in a hospital that, where people have to come in at the remote location. in terms of remote monitoring, it would depend, at the moment that wouldn't be classed as a non-admitted service event, because it is unlikely to meet that definition, but it is something that has been raised with us and we are considering into the future. So we are currently considering proposals for changes to the Tier 2 non-admitted services classification for 23-24. And as I said, we're looking into how virtual care and something more broad than, telephone and video conference can be captured as part of that classification. But it is a broader discussion of how we capture that in national data, because it's not just an issue for non-admitted, it's an issue across emergency departments and the admitted care as well.
Okay.
It's also an area where we're going to see more and more of this work as we've evolved into medi-hotels and the monitoring of COVID cases. And so I think there is a strong appetite amongst clinicians to work in this area, both in the area of admission avoidance, but also monitoring of the trajectory of patients in order to keep them out of hospital if at all possible.
Okay, so back to the subacute care classification, the AN-SNAP classification. What are the benefits of introducing frailty as a variable in the AN-SNAP classification, and how could clinicians and health managers use this information to inform health service planning for subacute and non-acute services?
I guess the benefit for incorporating frailty into the classification is that from a clinical perspective, we heard through our clinical advisory committee and through our subacute care working group and the clinical groups that are represented on that frailty was absolutely a big driver of cost in subacute and a cause for, it was causing complexity and length of stay, longer lengths of stay in subacute. And so we looked at different ways in which we could incorporate that into the classification. We did look at some clinical tools that were prospective and captured frailty at the beginning of an episode, but unfortunately those tools weren't collected in the national data available to IHACPA. So the frailty related index of comorbidities is using the existing coded data and providing a weight to codes that are frailty related, and it was based on a study. And there's a lot of detail about this in the final report that will be released in November. In terms of, I guess, service planning and the way it has been implemented, it is implemented as a retrospective measure, so it's based on the coded data. So the way we have implemented frailty is probably not going to be useful for clinicians to plan their services, but if we are able to implement Rockwood or another prospective measure into the future, that may assist. But I think, I don't know, Joe, if you have any thoughts on that service planning question, but, just understanding the type of patients you have coming through and the level of frailty that, is indicated by the frailty related index of comorbidities will help service managers to plan the future. I think ultimately we are an aging population. Frailty and comorbidities are increasingly becoming an issue for hospitals and hospital services, and having that information to hand allows planning to happen, with that from a place of knowledge as opposed to just guessing the types of patients we're seeing.
Okay, so I've got a question here on education. So I think the gist of the question is that that we have one group of people interpreting and using the encoded health information for the purpose of classification and funding, and another professional community responsible for encoding the information within the data. And the question is, why isn't some sort of education being offered, at least at the primary education level, I guess, to ensure that there's a to reinforce the standards and consistency of encoding of the data, and then understanding the context in which the data is being used. So, Anne, what is IHACPA doing around the education side of things? I know you answered one on education earlier, but maybe you could elaborate.
Yeah, so IHACPA's main focus in terms of classification development education is to educate new editions of the classifications, particularly to the clinical coding workforce for ICD-10AM at GACS who do apply the codes. In terms of ARDIGs, education to date has been a little less formal than that type of education, and we are anticipating developing some education in terms of the DRG for a wider range of stakeholders. But if the question is about the documentation side of the education and clinicians, I think there's probably a broader, there's something broader behind that, because the classification development, yes, relies on the documentation and the source material. And the clinicians in the hospital settings are responsible for that documentation, and jurisdictions themselves are responsible for the data quality. And so we want to work in partnership with groups to ensure all these things mesh together to get the, you know, optimal coded outcome that underpins so many other use cases. But our main focus in terms of educating classifications is to ensure that they're applied correctly and consistently so that they can service those multiple use cases. I'm not sure if anyone else wants to add to that, but that is the focus of our new edition education. Of course, there isn't a question about, you know, ongoing education and, you know, the whole point of, you know, educating coders themselves is not IHACPA's remit, but the new edition education is. I don't know if you wanted to add to that, Joe, or anyone else, but yeah, we're working to really try and provide a really solid educational package for the new edition education that will be released next year.
I just reiterate what you said there, Anne, that obviously we have an important role to play in education around the classifications, as do a lot of other agencies and health departments and health services. And so, as you said, we're keen to work in partnership to make sure that we're supplying the right education material, but also to work, you know, with, you know, sessions such as this, or, you know, to understand what other education requirements there might be.
I also think
so
we've had, sorry, I mean, IHACPA's been in this way, you know, assisting with the education of young doctors with respect to appropriate nomenclature with their Right app and other things to assist with, you know, with getting accurate information to the coders. And as we move from written medical records through scanned records into electronic records with decision support, I think increasingly, you know, that will more accurately reflect the appropriate information for coders.
So back to the mental health care classification, the AMHCC. Last year there was a phase of care pilot project suggesting a new phase of care definition. Are these concepts going to be in?
Yeah, so yes, last year we did run the mental health phase of care refinement testing project, and that was really to test some proposed new phases of care definitions. The outcome of that study was that the new definitions didn't really give us any greater inter-rater reliability than the existing definitions, and a recommendation was taken to the mental health working group around retaining the existing mental health phases of care definitions with some slight amendments to assessment only and acute. And that was accepted by the mental health working group. You know, there's been significant investment and training around those existing definitions, and they did not feel that the increase in inter-rater reliability warranted changing anything. It was quite marginal. However, IHACPA is currently developing an education program for mental health phase of care with some age-specific and setting-specific tools that will be released mid next year, I believe, which will hopefully improve the understanding and therefore the application of those definitions. And that testing project final report is available on the IHACPA website.
Okay, that's all we have time for today. Thank you for joining us this afternoon. I hope you found the session useful. Please take a moment to provide your feedback in the survey, which will appear on your screen very shortly. The next session in our series is scheduled for December. We'll take an insightful look at hospital costing, including our National Hospital Cost Data Collection, which underpins IHACPA's National Efficient Price Determination. To find out more, including the upcoming session topics and dates, head to our website, ihpa.gov.au/events. We look forward to seeing you at our next IHPA event. See you soon.